Before we dive in, I just wanted to throw out kind of a thought exercise for the providers on the line. We had a recent question of a patient, an employee, having a positive serology test, a positive IgG test, I believe from the Abbott serology testing, that came back positive, and they reported that they had had symptoms of loss of smell, loss of taste, some coughing, breathing difficulty for about 2 weeks towards the end of March. And I guess my question to you would be, is there any concern for being contagious? Would you check a nasal PCR for this patient? Would you have them stay out of work for a period of time with this new positive serology? Or would you just let them be? Anyone have any thoughts?
Edwin,
Yeah.
I think, and so with the positive serology test, and she was able to pinpoint her symptoms and the time frame of those symptoms, that made me less concerned, I guess, because, and I'm not trying to give an opinion on what you're asking, but more so just detailing this patient specifically. So she's able to kind of describe when her symptoms were and when she was believed to possibly have been infected in the end of March. And so from my perspective and being and knowing this person and that just now receiving that positive antibody test, it's less of like, I guess, the concern of returning to work and whatnot because symptoms are able to be pinpointed potentially. But I guess it may be more of a question of what about a lot of these folks who are going to get antibody tests too and can't pinpoint symptoms and were never symptomatic. The question of when they were infected and that crossover window of, you know, infectivity and having a positive antibody, there's that crossover time period. So I feel like that comes into play too. Just kind of throwing that out there.
Right now, I don't think there's any guidance in the hospital system for us for what to do with these positive serologies in terms of something like that. I'm not sure employee health has something set up either. Any other thoughts?
Yeah, in all likelihood, if she had symptoms 2 months, end of March, this is now end of May, 2 months ago, and I don't think we have any data suggesting that people can be infectious for months on end. However, this is a new situation for us. So since it's new, it would not be unreasonable to do a nasopharyngeal swab and do this the first 10 times that we have such a situation, and we'll probably find 0 out of 10 are still carrying the virus. Then we will be reassured. So we could test in order to reassure ourselves and also generate some data that will help others in the future to know how to handle the situation.
Okay, this is Jerry, and I got a couple thoughts. First of all, this patient fits what we're going to use, what DHEC's going to use as the case definition for a probable case, I think. They have fairly clearly defining symptoms, from what I heard you say anyway, including the loss of nasal, you know, the anosmia and so on, plus at least 1 or 2 other symptoms. Plus she had, I assume, a FDA EUA approved serology. So I think we have to go on the working assumption she had COVID back then. We have several good studies now showing that by about 10 days, in fact, actually by about 7 days after onset of symptoms, people are no longer infectious again. That's the basis for, as we know, for releasing people to go back to work again from discharging them from the hospital or discharging them from isolation, which can be time. So it seems to me that there is excellent evidence to think this person is no longer infectious. We also know a number of papers showing that people shed RNA, viral RNA, which unfortunately gives you a positive PCR, but all the evidence we've seen from Korea and from here, and they cite several papers on this, are that these are not live infectious viruses for about 7 to 10 days after the onset of symptoms. So I think this person, just from what I think I've heard from you, Edwin, is pretty clearly somebody who you would assume had a probable case of coronavirus and is no longer infectious. People buy that?
Yeah, this is Mike Katchka. I was just going to say, I agree that this is something that DHEC would classify as a probable case. Because they're 10 days outside the onset of their symptoms, we wouldn't consider them contagious, and they would be not recommended for any isolation and could return to work.
Anyone have any other thoughts about that? Any utility to getting nasal PCRs, or would you just say this is done?
The nasal PCR might be positive, looking at some recent studies, but the evidence suggests that it would be RNA, not infectious viruses. What do you think about that, Mike?
That potentially would be a concern that they would come back positive. It would be interesting to see if you do an NP swab and it comes back positive, then they would have to stay out of work and stay in isolation for 10 days after that test is collected, assuming they no longer have symptoms.
Yeah, you almost wonder, do you want to go down that road for what you'd be committing to? And of course, the other challenging thing moving forward will be people who have no symptoms at any time, who have a positive serology all of a sudden and can't recall a period of being ill. Any other thoughts on that before we move forward? Just an interesting exercise, something that we've seen and we're going to see a lot more of.
A real exercise.
That's real.
Well, in that case, I think, Dr. Derek, if you'd like to move forward with your presentation, talking a little bit about plasma donation, we'll go ahead and get rolling with our presentations. Thank you very much. Can you see
my slides? Can you see my slides?
Yes, I can.
Yeah. Okay. So my name's Caroline. I'm one of the ID pharmacists here at the Prisma Midlands and with the USC School of Medicine. So I have been working on plasma donors and kind of recruitment of plasma donors. And so I'm going to walk through a little bit about our experience, what we've done in the past, what we're currently doing, and then kind of our hopes for moving forward. I'm trying to keep it where I can see some of you guys, but if you do have questions or comments, feel free to chime in and say anything or stop me if I say something that's confusing or incorrect. And so this just kind of narrates what I'm going to go through. And so when I first heard about our initiatives at the hospital, specifically Prisma Midlands Hospital, Dr. Albrecht said there's going to be a van, and there's going to be a van on Friday, and we need donors. We need plasma donors. And we said, this Friday? And what kind of van? And what's going on? What do we need to do? And so we kind of had to there was a lot of coordination in the background to try and see how to make, how we could really make this a successful plasma drive, because it was our first time trying to do something like this specifically for COVID. And so those people listed here, Drs. Albrecht, Wiseman, Ahuja, Dr. Jenkins specifically, who was so helpful and really instrumental in having personal relationships with a lot of folks that she knew, and she was really important in assisting us with getting us some donors for these first donations. So big kudos to her for that. And Dr. Rayner with the Blood Connection has been so kind of wonderful and available throughout all of this, because there's been a lot of questions for him. So he's a member of the Prisma team and also a physician for the head physician for the Blood Connection. So we had 2 plasma drives at Baptist Park Ridge Hospital. I have the dates listed there, and there were 8 slots on each day. And so we were able to fill up the 8 slots. And each donor can potentially give up to 4 recipients, and that's based on blood volume and a few other things that they go into to make sure that the donor is an appropriate donor and whatnot. But we were able to fill up all the slots. And kind of how we did that was we really cold called people and used close connections of knowing people to see hopefully if they would show up for us, and they really did. And so I'd say to get 16 donations, there was probably 60 charts reviewed and maybe 50 phone calls to try and then once we got people on the phone, they were amazing. I mean, they really wanted to help. And so folks have been very willing to do something. They almost want to help if they can. Again, this was over a month ago, so very early on. And there wasn't a whole lot out there about what folks could do. So they were really interested in trying to help. So now we're not doing the vans that come to the locations. The Blood Connection will do that, and we'll set that up for you. If you have a group of people that live in a certain area and you need to have them come to you, that's definitely an option. They also have locations that are listed here for you, and there's more than this. And so they do have a mobile bus that they can send out to certain locations. There's hubs of donors. But what we're currently doing is trying to get people in contact with the Blood Connection so we can work through them to really funnel them to the USC Student Health Center if they're located in our area, because that's a site that is open Monday through Friday, 10 to 3 about, and they are accepting donations there. And so now they've made their health history questionnaire available online, which is really nice. So you can go and kind of see the questions that they ask to pre-screen these donors, which is really nice. And so this is just kind of a summary sheet on kind of where we're shifting towards with coordinating with the Blood Connection. But specifically what we're doing when we're trying to recruit a donor is not call someone that there's no way that they fit, right? So we want to make sure we're calling people appropriately and making sure that they fit criteria before we just send over anyone to the Blood Connection and there's no way that they would be able to donate. So we're trying to really get solid donors to the Blood Connection, to the Student Health Center to make sure we do our part in sending over good candidates. So the big picture criteria, one, it's kind of evolving. And so it was not this that's listed here for you previously, but this is current and posted in the beginning of May. So a diagnostic test you can see listed here, or a positive antibody test is acceptable. So a PCR or an antibody test is acceptable, and the patient needs to be symptom-free for 14 days. Now there's more there's more details along the way, of course. If you're a female that's had children, they'll do HLA testing, and Dr. Rayner specifically, if he knows about certain cases, then there's exceptions to the rules. But for the most part, this is the FDA requirements I have listed here for you. And that's what we're trying to go by specifically for. You need a test of some sort, and you need to be symptom-free for over 2 weeks. Usually we're saying that test needs to be done 28 days prior to donation day, but that 28-day mark isn't listed here for us right now in this verbiage, but that's kind of the standard approach that we've been taking and the rule that we've been following. Now, what do these people need in their hands? So when I'm calling these folks and saying, you know, you fit these criteria, you're willing to donate, can they just show up? What does that look like? They need something in their hand to say it's true that I was positive or that I have antibodies. So there needs to be something that they can hold on to, and not just like a scribble, you know, I was positive. It really needs to be a copy of the result via a valid document through a certified testing center with some sort of provider attestation. So some sort of something that says, you know, you can return to work because you were positive on this day and the provider has cleared you. That's a solid work excuse, and that'll work. And so all these questions have come up along the way because people don't always have a copy of their test or something in their hand that says they can return to work, or whatever the case may be. So I've done a lot of back and forth with the blood collection on what's acceptable for this. And so this is kind of the current status of where we are right now. Now, I've been, for the vans or for our calls right now, helping, if we have access to this, helping our patients get access to this information so that they can then have it in their hand for donation. And so questions that I've received along the way are, say my cousin's brother is in the hospital right now, can I donate directly to them? Or is this going to cost me to donate? But I've been positive, but my husband, is it going to cost him to get antibody tested? And can I use the test we bought from Walgreens? So those are just like a few of the types of questions that get thrown around. And so I'll try and walk through some of that. So the first one being blood compatibility and directed donation. I have this chart here for you. Can y'all see the whole screen, or do y'all see the picture? You can see the screen? Okay. I won't walk through this, but I think the first lesson I learned is that blood and plasma donation is not the same. Blood types and matching, the whole process is a little bit different for plasma donation. So just something to keep in mind, that it is very nuanced and specific. And so directed donation, sometimes people may know the blood type of the person and just get a little bit confused on if they're compatible. So I think that's something that we have to pay specific attention to along the way. But specifically, if they are a match, there is a process for directed donation. And so it is something that is feasible. It's something that we can coordinate. And the Blood Connection has been very helpful and amazing in trying to coordinate this with us if that has been a specific request. This is the form that has to be filled out, and it's on their website. Cost. So to donate, they won't get charged, but through the Blood Connection, they also won't get paid. And so that's something to know. And then if they want to go get antibody tested, if they are saying, sure, I'll donate, but my cousin wants to get antibody tested, that comes up in these conversations. And so Prisma Health, the cost, the cash price through our system is $154. But in the future, we're going to try, and it's going to be something that employees should be able to get tested at no cost. If you have insurance through Prisma Health, it's going to probably be no charge. But we do have employees who are PRN or part-time, and I've specifically had this question. So do they need to pay $154? To be determined. So something I learned today is that the Blood Connection, as of about a week ago, if you go to donate whole blood, they will antibody test your blood. So we had someone, I was just talking to a provider through our hospital, the one without insurance, and she's like, I donate blood, I'll donate blood, and then in turn, she'll get that antibody test result. And so I think that that's something that is very beneficial to know and kind of encouraging to maybe go get more blood donors. And whole blood donors don't need an appointment. And so they can just go donate at the Student Health Center. And then I have the prices listed there for Quest and LabCorp. And so let me see if I walk through. So the tests that, there's a few tests that are available that are approved. The Abbott test is the one that our system is using. And so kind of to the previous case that Dr. Hayes was mentioning before we really started up, this is the test result. So I had someone that I knew that was trying to help me figure out this process of antibody testing and what it really looked like for the community. And so she went to LabCorp online, got it covered through her insurance, paid $10, and got her positive antibody result in about a day. And so you can see here, this is what the result looks like, and the turnaround time is fairly quick. And so I think that we could be encouraging folks to do this for donations specifically, now that this is a approved modality to be, positive, your antibody test. So what we're doing right now is really just continuation of where we were. We're cold calling people. Physicians are giving us folks, and physicians are helping us. It's a group of pharmacists, but really the student volunteers through the pharmacy school are working with me. And it's an extensive process to be labeled a student volunteer right now. You can't just come and walk onto campus, right, as a student. So you can't be in any clinical areas. There's designated space, masking, et cetera, and then registration. So this group has gone through that process, and they're working with me to try and expand our donor pool. These are our students that are doing their due diligence in helping us work to expand the process, and we're working on trying to make sure we do it the right way. So making sure we're screening folks appropriately. And this is just an example of our Excel that we're trying to document, if we're calling people, if they answered, are they willing, do they fit the criteria, so that we're doing our part in making sure we're not sending the blood connection folks that really don't fit or wouldn't be good candidates. So in the future, our goals, try and get this information out there. This is a flyer that we made. One of my students actually made it. I think she's on the call. There was a tag team of them that made this through some fancy something. I don't even know how to do this, but kind of summarizes the things that we talked about: who's eligible, contact numbers, fax numbers, and that we're really partnered with the Blood Connection and the Student Health Center. And they've screened over 100 patients, called almost half of them, and had 22 streamlined to the Blood Connection thus far. And so they've really been kind of instrumental in doing that over the past few days. This is only over about 4 days' time. I won't go too much into what happens after that, because I think Dr. Ahuja is going to talk more about the recipient process and more details of what that looks like. But each patient that receives the plasma in the hospital, there's a whole process for making sure that that's done appropriately through the Mayo Clinic process right now. So I won't go into a lot of detail about that. But we've had a lot of advocates that have been very helpful in this process. So member of the House of Representatives, I think, Neil Collins has been fabulous. I think discussions like this, just kind of getting the word out, have been very helpful. If we could do more in terms of facilitating through emails or even the media to try and get the information out there that this is happening and this is kind of how to go about the process. So I just kind of wanted to touch on that a little bit. And if there's any questions or comments, I'll check the chat box now. But if there's anything, just let me know.
So Caroline, I just want to say thank you so much for the work you're doing with this. I think this is very valuable stuff. And, we could talk a little bit about some of the anecdotal stuff we've seen with plasma being useful for people. We'll probably talk a little bit more about the treatments in a second. But a couple of things I'll say. One, it's interesting some of how the cultural pressures have shifted some of the guidance, like for blood donation, blood product donation. I think it was in April, correct me if I'm wrong, anybody, but in April, the FDA shifted some of their exclusionary recommendations for people who donate blood. So men having sex with men, people going to malaria areas, went from a 12-month exposure from a sexual experience or from going to that country to a 3-month exposure. And they got rid of the whole Crooksville-Jacob thing. So people going to European areas previously or on a military base, I don't believe that that's any longer an exclusionary criteria for blood products. And that's from April, probably in part because of the pressure of what's happening with COVID right now. One caveat that's interesting is I believe, and correct me if I'm wrong, there's still an exclusion for prisoners. One of the populations that's really blowing up right now, one of our most vulnerable populations, they cannot donate blood until 1 year after leaving prison. So that is still an issue. But some of those recommendations have kind of shifted to open up more of the pool of who can donate blood. And I thought that was interesting. I think there's some controversy to men having sex with men being excluded from donating blood at all, personally. Is there a comment to that? Mary?
What I will say to that, Edwin, is I was under that impression as well, that some of those restrictions have been lifted. But when I was on the Blood Connections website today, doing the pre-screen criteria, that I put the link in here somewhere, that criteria still shows up as something to at least be answered, a question to be answered. So it's something that's still being evaluated in some of the pre-screening criteria.
That's
Can I ask a question? Yeah. Good.
Yeah.
Yeah, I put it down in the chat box too.
Oh,
How did you decide on the 1 to 80 titer criterion? The reason is I remember from some earlier webinars and other data that Mount Sinai in New York is doing this, and they're taking 1 to 320 as their criterion for convalescent sera that they want to use.
sorry, the chat box, I was looking for the question. Were you referring to in the criteria for the FDA?
The titer of blood that you'll accept for plasma for donation.
So this information is straight off the FDA website. So this is a screenshot of the criteria from the FDA website. So this isn't something that we've really manipulated or made a decision on. Maybe one of the providers has a better understanding of that, but this is straight from the FDA criteria that they've listed.
May I just, this is a Divya, Jerry, just to answer your question, if I understand it correctly, I don't think you're asking, are they doing quantitative titers on plasma? Is that what you're asking?
Yeah, I misspeak. No. Well, you have a note here saying that you would expect a neutralizing titer of at least 1 to 160.
Yeah, but currently they are not screening based on quantitative titers. It is just based on whether you are a survivor and you are past a certain deadline, as Dr. Derek pointed out, and you're past a certain deadline so that you don't infect the blood bank people. That's probably one of the main sort of things. But people are doing it, but at present in South Carolina, there is not a screening tool, but it is being done across the country in different settings to check quantitative titers in donated plasma.
Yeah, it's something that they can bring with them if they have it, how it says if available for some reason if it was checked, but it's not something that they're doing upon the patient showing up per se at the Blood Connection specifically. And go ahead, Dr. Ahuja. I'll stop. I think I'm trying to stop sharing. Did it work?
Yep, I don't see it now, but yeah, Dr. Ahuja, this is probably a great segue. If you'd like to talk to us a little bit about an update of what it's like being a clinical doctor doing infectious diseases with these cases and COVID-19 in general.
Hear me and see me?
Hear you and see you.
Okay, thank you. Thank you, Dr. Hayes, and thank you, Dr. Derek, for that. Certainly, very important work to contact these people. And it's a tricky time. What Dr. Derek and our colleagues are doing is contacting people who may have lost somebody to COVID, and yet they are very willing to donate, almost desperate to donate as a sort of closure. And we know of cases like that where people want to donate to sort of put closure to this sort of tragic times. So it's certainly been very, and this is going to increase more and more. So let's just run. I have a few slides that they're a bit of a hodgepodge because they're made up in the last sort of 10 minutes, so forgive me. But I gave a talk this morning to the emergency department at Prisma. So I just prepared this slide at 6:30 in the morning. It has obviously changed since then. As of 5.6 million cases around the world, and global deaths, 350,000. You all know these numbers. What about South Carolina? As of yesterday, South Carolina labs across the state had completed 178,000 tests, more than 10,000 confirmed cases. It is believed from the health department, and I know there are lots of colleagues from the health department, they can correct me, but it is estimated that many, many more are infected but have not been tested. The data that is given here, and I don't know whether you can see the cursor on the screen, Edwin, when I do this, but as of yesterday, based on South Carolina Hospital Association data, there were 438 hospitalized patients, about 56 in the ICU as of yesterday. Couple of words about the antibody detection. It was just being talked about. Dr. Hayes, Dr. Derek talked about that. The first antibody that goes up probably is the IgA. It's a mucosal antibody, goes up in the nose, and there are some labs that are testing IgA. We don't know how reliable it is. The next one that goes up very close to that is the IgM. So the first thing that goes up, like with any viral infection, is the viral RNA. Then the antigen goes up. The antigen test is available. It is not very reliable at present. Sensitivity is extremely low. Then the IgA goes up. Most labs are not offering IgA, but some labs are. So if you see an IgA, it's a mucosal antibody, and it is being done by some labs. Very soon after that, the IgM goes up. And in this infection, unlike other viral infections, the time gap between IgM and IgG is very narrow. IgM and IgG go up almost simultaneously. And then after that, it's anybody's guess how long the IgG stays. Does it provide protection? And there are some great primers out there. And the CDC published its antibody recommendations about 2-3 days ago, where they say antibody should not be used to diagnose a case. At present, the best way to diagnose a case is using a RT-PCR. Having said that, that is not a great test, but it's the best we have. And then the antibody tests include qualitative assays, which are point of care assays, and then the quantitative assays that Dr. Gibson was talking about, check the amount of antibody in you. And that's not easily available yet. It is being looked at in lab settings, in research settings, but most of the tests that are available commercially are qualitative assays. Yes to IgM or no, yes to IgG or no, or yes to total antibody. Prisma has two different antibody tests. One is the Abbott IgG, which is in the lab. Abbott claims it is 99% or 98% sensitive and specific. So that means it doesn't include the previous coronaviruses that caused, and Edwin, let me know in terms of time when you want me to stop. But the Abbott assay is supposed to be very sensitive and specific. A lot of institutions, hospitals, healthcare systems like Prisma, universities like University of South Carolina, utilities like frontline utility companies in various counties are going to be using antibody assays to sero-sort people to figure out, do their frontline providers, are they at risk or have they already been infected if they're IgG positive? The downside is, and you can look at the CDC publication that came out 2-3 days ago, if you do antibody testing in a low prevalence area, so if your pre-test probability is low, and it is believed that in South Carolina, maybe 2-3% of people are infected at the most. So if you do it in a low prevalence county, you will get a lot of false positives. So using the antibody in a low prevalence area where your pre-test probability is low will lead to a poor positive predictive value. And that is the downside of doing seroprevalence in areas of low prevalence, in rural areas of South Carolina. So once again, as we go into this, as we understand this a little bit more, remember doing it in a high prevalence area, it has a better predictive value. In a low prevalence area, it has a low positive predictive value and lots of false positives. And that's all I have to say about antibodies. I could say a whole lot more, but I'm going to stop. Any questions on antibody, or is somebody going to address this later, Edwin, or I'll just carry on?
We'll address it a little bit later.
Okay, so I'm going to skip over this slide. The convalescent plasma we talked about is a convalescent plasma that Dr. Derek and our colleagues are getting people to donate. Once it is donated, a male can donate about 4 convalescent plasmas of 200 cc's each. A woman, depending on if whole blood is collected, blah, 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 you can donate 1 or 2. Each convalescent plasma is about 200 cc's. And that 200 cc's is thawed, is typed and crossed, brought to the blood bank, thawed, and given to the patient. It can be given over 30 minutes or an hour. Most side effects are very minimal, but you can have all these, transfusion-related acute lung injury, transfusion-related febrile reactions, etc. And I'm showing you a picture of this patient because she's been on TV multiple times, and she's been a great advocate for this. This is a colleague of ours. She's a nurse. She came down with COVID and was admitted to the hospital about I'm blanking on, maybe 3-4 weeks ago. I don't remember. But it was on a Sunday. Myself, Dr. Albrecht, and Dr. Rayner from Blood Connections worked very hard to get her plasma. That plasma came from Chattanooga, Tennessee. She was transfused with that plasma on Monday. By Tuesday morning, her sense of taste and sense of smell had improved. And by Wednesday morning, she was discharged. She was on the verge of getting to the ICU. She was the first person in the state to get the plasma, and she's been a great advocate for that. And a couple of days ago, she actually spoke with her donor from Tennessee and thanked her on a sort of televised conference. We also organized the first plasma donation that same week. Wrong way. The second patient was a little bit different. This we got, this plasma we obtained 2-3 days after the first patient, the picture I just showed you. This was the second one in the state. This was a very sick patient who was in the ICU, who'd been there for 14 days, they'd done prone, APRV, 3 pressors, and the family, he was a 56-year-old guy. Family was actually talking about pulling all support and basically making him comfort care. On Thursday, one of our colleagues, name is listed here, Janet, she's a PharmD fellow, who called multiple blood banks, was able to find one appropriate plasma in New York. That plasma, so at that time it was so difficult to get. That's why what Dr. Derek is doing is so important. That plasma was FedExed on Thursday, and this guy who was more than half dead actually was extubated 3 days later and discharged. He actually went home, which is amazing. He was almost dead. So this study came out of Houston just a few days ago. They had 25 patients with severe. So we've had some good responses, not all of them. We've given quite a few plasmas. When I registered the first patient, she was 300th in the country. Now we are up to 21,000 plasmas have been given in the country. This is a study out of Houston, saw 25 patients. 25 patients got plasma. They were severely sick. 76 got better. But, when they looked at the donors, and these are the 4 boxes, 4 of the donors had no detectable antibody in their plasma, and yet these patients got better. So what were they giving to these patients, and how did they get better? Who knows? The point is, not all plasma is perfect. Not all plasma has adequate amount of antibody. And even if it does have adequate amount of antibody, if not given at the right time, if given too late, it is neither antiviral nor is it immune modulatory. So we still don't know enough about this, but in some situations it is worth giving. What we are doing now is trying to give it to everybody, provided there are no major contraindications, because it is well tolerated. If it helps a little bit, it's worth it. 2-3 slides, and it's 7. I'm going to stop in 5 minutes. I know I've gone on, but let's stop. I just want to show you. So there's a complicated slide of immune modulators. I want you all to memorize it. We'll, in just 30 seconds. But having memorized this, I want to show you this case. There's a medical resident. He was admitted like this, not admitted like this. This when he was diagnosed about 10 days ago. This is him 2 days or 3 days later when he got admitted, and this is him 2 days later. Very, very sick. We gave him this drug called tocilizumab, which as a lot of you know, is IL-6 antagonist. And this is what he was like before he was when he was admitted to the hospital. This is his temperature. This is his heart rate. This is his respiratory rate. He'd been like this for 4 days. We gave him tocilizumab at 8:30 p.m. on Sunday night, today's not this Sunday, but the past Sunday gone. I came in to see him. We gave him tocilizumab. After that, he never had a single temperature. His heart rate, look at that. His heart rate almost just completely normalized. And look at the respiratory rate. Right here, he was given tocilizumab. So once again, just like plasma, if a IL-6 antagonist or a JAK inhibitor, which is now being studied like baricitinib, if you give it at the right time, whether it is tocilizumab or siltuximab or sirolimus, it works beautifully. But if you give it too late, and then now people are saying there are certain IL-6 polymorphisms that might predict your response. But anyway, two slides on remdesivir. Is somebody going to talk of remdesivir, Edwin?
No, no,
Okay.
sir.
Then 2 slides on remdesivir. Everybody's heard about it. May 22, 1,000 patients through the NIH ACTT1 study that showed that, yes, 1,000 patients who were randomized, 50% to remdesivir, 50% to placebo, and remdesivir is a RNA polymerase inhibitor. It basically stops replication of the RNA virus, which is this coronavirus. And they found that recovery time was better with remdesivir, mortality was better, as well as adverse events were not too bad. Currently, all the remdesivir is allocated to the health department. The health department has about 1,500 5-day courses. It is being distributed equitably around the state. There is an online application process, and we are encouraging people to consider everybody for remdesivir. But because it's in limited supply, don't give it to somebody who would not have a long life expectancy if they didn't have COVID. We are not discriminating. We are just trying to make sure we get the most out of this limited supply of drug. And the health department wants to do it the right way. They're doing it the right way. They have a clinical advisory group. They have an ethics advisory group. There is an online portal. Everybody's available for questions. They want to give it to as many people as possible. But the supply that we have in the state is maybe the only supply the state will get for the next 30 or 40 days. Therefore, these 1,500 doses may have to be spread out for the next 30 or 40 days. So it's a drug that works, has to be given early. But if somebody has ARDS and is on 3 pressors, it's probably too late to give remdesivir. Or, so use your clinical judgment. Use it for those where you sense a recovery is possible or where their pre-functional status was reasonably okay, that this drug would make a difference. And I'm going to stop after this slide. A lot of you might want to know about this. This is being talked about all the time, and the CDC has some stuff and some criteria. Anyway, I'm going to stop, but there's some great stuff on this multi-inflammatory syndrome in kids. And now there are, so anyways, okay. So I'm just going to stop there. Sorry if I went overboard. I'm going to stop sharing the screen.
No, that's great. Thank you, Dr. Ahuja, for kind of giving that picture of what it's like clinically and what we're kind of on the crest of right now, dealing with all of this. Does anyone have any questions for Dr. Ahuja about any of that? Okay, very good. Well, thank you very much, Dr. Ahuja. I think we're going to move to our next case then. Dr. Ben Thompson is joining us from the palliative care side of things to talk a little bit about what it's been like to manage patients dealing with end-of-life challenges and social issues and these emotional issues in the setting of COVID-19, which I'm sure is going to be challenging, as you can imagine. Dr. Thompson, I'll let you take it away.
Great. Are y'all able to hear me okay and see my screen?
I can hear you and see you.
Great. Well, thank you so much for inviting me. It's always nice to do these interdisciplinary conferences and hearing some of the challenges that you're facing are some of the things that we think a lot about. Dr. Ahuja just mentioned scarce resource allocation, and for a while at the very beginning of the COVID era, we were concerned that we were going to be facing situations like New York City, where they were allocating ventilators, and thinking about how are we going to decide who gets treatment and who doesn't. One of the things I wanted to talk about was that at the beginning, palliative care was brought into the coronavirus sort of protocol as a group that would help decide who would be responsible for allocating those resources, and eventually, ultimately, who would receive a ventilator, who would receive scarce resources. And that's been a real struggle. I think that, you know, when Dr. Ahuja said, let's think about who has, you know, who could have a meaningful quality of life or a meaningful recovery, there are so many different criteria and so many different scales that people use to think about that. Is someone who's 55 and at baseline bedbound and non-communicative after a CVA, but is tube fed and maybe could reasonably live an extra 20 years, is that a better quality of life than someone who's 80 and at baseline healthy and maybe could live another 5 or 10 years? So we've had a lot of difficult conversations regarding resource allocations. I titled this talk Palliative Care in the Era of COVID-19 because I wanted to talk a little bit about how our entire system has been affected, not just caring for the patients with COVID-19. So I wanted to just help you all understand what's going on from the perspective of a palliative care physician and some of the challenges that we faced. The two big ones that I want to talk about are prognosis, prognostication, and visitation, and some of the challenges that that's brought for us. I can't do a palliative care talk without doing a what is palliative care slide. So we are a specialty trained team of physicians, nurses, who provide an extra layer of support. It's appropriate to give palliative care at any age and any stage of disease. This can be provided along with curative treatment. So often we're brought in when patients are at the final stage of disease and you know, and maybe actively dying, maybe would benefit from a hospice referral. But there's so much decision making along the way that we can help with, that we can provide support to families, that, you know, it's helpful for us to be brought in at the time of diagnosis. Again, it's based on the need for care, not on prognosis. For example, I have a patient that I was consulted on recently who has heart failure and is, you know, from a heart failure standpoint, pretty stable, but his caregiver is his daughter, and she's facing a lot of burnout now. So they have an extreme amount of palliative care need as a patient caregiver dyad, where his prognosis, you know, while he does have some heart failure, it's not a severely life-limiting prognosis. So why do we get consulted in the hospital? A lot of code status. People say, well, this 120-year-old has multi-organ failure and they're a full code, and they probably shouldn't be. So we're brought in at that point to talk about what resuscitative efforts would look like. And then a lot of end-of-life conversations, like I mentioned. We do symptom management, family support, and medical decision-making, but I would say that for the most part, our consults are for goals of care, helping people understand what being a full code means and what interventions they're signed up for, and then discussing, you know, transitioning from curative treatments to comfort-focused treatments. So what would a presentation be without a case? This was a guy in his 60s. He had some health problems. He had atrial fibrillation on Eliquis. He was on peritoneal dialysis for 3 years, just to give you an idea of his compliance and his you know, ability to be compliant with treatment previously. He was at home and he was on his deck and he had a fall and sustained head trauma, as you can see by the CT scan. Initially, ID was consulted for a COVID rule out because he was tachypnic, and they quickly said that this wasn't a COVID issue. This was due to a head trauma from a fall when he was on a blood thinner. CT was ordered, and he had hemorrhages in his frontal lobe, occipital lobe, and the cerebellum. Initially admitted to the ICU with the neurosurgery team consulted. At this time, he was still able to talk, a little confused. His GCS was 13, and this was for about 5 days when they were doing every hour neurologic checks. Suddenly, he had a change in his mental status. At that point, he was intubated. A repeat imaging showed that his swelling had gotten out of control. He'd had a midline shift. He'd had edema. So they started all of these interventions, hypertonic, but they said, well, maybe a hemicraniectomy wouldn't benefit him at this point. And during this time, hospital 8, 5, 6, and 7, his neurologic exam is continuing to worsen. So a week after he's admitted with this bleed, palliative care was consulted to start weighing through options for future treatment. We were able to speak with the patient's wife and daughter and actually get them to come into the hospital. Most hospitals have a limited visitation restriction, and for us, the restriction is that 3 family members can come in for 1 hour for either intensive medical decision making, for an extubation, or an end of life situation. So we brought them in just to think about what the future options would be. And at that time, an MRI was ordered. The family was really concerned about what would happen if we transitioned to comfort care. And this is the point of the case. They thought, well, in a normal situation, we would be with him 24 hours a day until he passes away. But given that visitation is limited to an hour, we're afraid of transitioning to focusing exclusively on his comfort or admitting to hospice, because we're afraid that he'll live longer than an hour and will be kicked out of the intensive care unit, and then he'll die alone in a hospital room, which was clearly not what he wanted. So we got the MRI, and the MRI, as y'all can see, is devastating. I just showed the frontal lobe injury and the cerebellar injury. And given that this was someone for whom independence was paramount, this was not going to be an injury that would be compatible with meaningful quality of life for him. The family understood that, and they said, well, we don't want him to die alone. So our team arranged a transport for him. So our plan was he was intubated on PRVC, 40% FiO2. He was still breathing over the ventilator, and his blood pressures were in the 150s systolic. So at the time that we arranged everything, it appeared that he would survive longer than an hour, and hopefully would be able to make it home. His family's goal was for him not to die alone. So I talked about the impact of our visitation policy. There's no hospice-specific policy. There's nothing that says a family is able to stay 24 hours a day if they don't leave. Families, who don't visit are then being asked to make decisions without seeing how a patient is. We had a patient who'd had a stroke while in the hospital. So the family had seen him go into the hospital one way, and his neurologic status, his quality of life had changed significantly. And we can tell people about it, but without them actually laying eyes or being able to talk or see their family member who's unable to talk, it's difficult for them to make life and death decisions. And of course, we would hope that visitation would reduce delirium. though I recently saw a study that showed that liberal family visitation compared to strict visitation didn't have any effect on hospital-induced delirium. So, like I mentioned, we arranged home hospice for this guy. He was on dialysis and received dialysis the morning of transfer. After dialysis, his systolic blood pressure was 70, and he had stopped breathing faster than the ventilator. The family came in, and I explained to them that it seemed like our plan wasn't going to work for him to go home. After he was extubated, he didn't take a single breath on his own, which was sad. But we had a plan in case he had lived longer, and he was able to die surrounded by his family, which was their primary goal, was for him not to die alone in the hospital. It's a lot of death and difficult family dynamics and situations, but when you think about all the possible outcomes, this one honored our patient's goal. So the other thing I wanted to talk about was prognosis. I know y'all have seen different graphs of what prognosis looks like for different medical conditions. So the red line on top is typically the illness trajectory that you'd see with cancer. From the time of diagnosis, someone might get a little better after some initial treatment, then have a predictable decline until they die. The middle line is typically organ failure with exacerbations. People get worse during an exacerbation of heart failure or of COPD, and they recover, but maybe not quite to the extent that they were before. And the bottom line is Alzheimer's or other dementia, where people have a low functional status that can persist for a very long time at a low level. I did draw this graph yourself, in case you're wondering, because I didn't want to add in a citation for this graph. So, did I do that again? Okay. So this is a big part of what we do in palliative care, is help people understand what they're going to see as their illness or as their loved one's illness progresses. But what is the illness trajectory of coronavirus that we've seen? For different diseases, we have scores that can say, well, here's your likelihood of mortality. Here's sort of the morbidity that we expect from you as your illness progresses. And I would argue that I'm not able to tell people, is this someone who's going to get worse, or is this someone who's going to get better? In terms of the COVID-specific prognostic calculators, there have been some smaller studies out of the University of Washington published in early April of what happened to people who were admitted to the ICU. Small samples, and they don't give a very good idea of prognosis. There was one study that said, well, 2/3 of people greater than 70 years old intubated in the ICU are going to die. Other studies, and then there's calculators that have come out and said, okay, we know that there's at least a 20% mortality based on this person's age, but also if they have kidney failure, that's not good, or if they have COPD, that's not good, but it's not able to really tell us, how bad is it, and what is the odds that they're not going to survive the hospital stay. We can all agree, sort of just by eyeballing a patient, someone who's 85, who has COPD and is on 3 pressors is going to have a much worse prognosis than someone who's healthy and 55, maybe like the nurse that you mentioned, Dr. Ahuja, who isn't having signs of organ failure. So I would say that I've kind of seen all three. I mean, you would argue that the exacerbation pattern of organ failure isn't something that folks who are getting worse with coronavirus are alive long enough to demonstrate. But you can see people, initially have renal failure and then go on dialysis and appear to improve and then worsen. We've seen a lot of folks from nursing homes and facilities who had a baseline dementia who sort of happened to have coronavirus and then passed away from that. And also people who've been relatively healthy who've gone downhill very quickly and died. So when we're counseling patients and their families, it's just been a very difficult thing for us to say, this is what you're looking at and this is what's going to happen. I tend to say things like, this is unlike anything we've ever seen. And I wish I could tell you exactly what's going to happen in the future. From some small studies, we know that age, other organ failure is negative in terms of someone's ability to recover. Our palliative care team had an initiative called A Pause to Remember. This was after we looked at all the nursing staff and the providers taking care of patients. There was a lot of burnout from work hours, from worry from family of providers who are facing the relentless news cycle of COVID, and just a lot of distress. I think initially we were so concerned about what coronavirus was going to look like that there were patients who we said, no, nothing that we do is going to help. And maybe in retrospect, 6 weeks later, we said, well, maybe remdesivir, maybe the convalescent plasma might have been able to help this patient had we known. So we saw a lot of burnout, and we developed a 15-minute intervention. We had a harpist and a brief prayer from our chaplain, sort of to a multi-faith community that was very well received. It's been done in our intensive care units and on our sort of floor COVID unit. We're planning to go to the heart hospital next week. It's just my last slide is that it's so important for us to update families frequently. And when we start an update for families, people who aren't able to come in and see their loved ones, to say, I'm just calling to give you an update. There are no major changes, as sort of the first words out of your mouth, because the families are also seeing the same news media that we are, and how deadly this disease can be. And for a lot of people, they think anytime the phone rings from the hospital, they have a worry that maybe their loved one has died. I mentioned prognosis and just vulnerability. The more you update a family, the more trust they have, and the more they're willing to listen to you when you tell them that maybe things aren't going as well as they could. So thanks for letting me speak with y'all. This is my team. We have 4 nurse practitioners. I'm one of 2 fellows, 2 physicians, a chaplain, and 2 social workers. If there's anything else I could do, there's my Twitter handle and my email address. Any questions for me?
Dr. Thompson, you mentioned earlier about the visitation issues. Do we have any kind of policies in place to make sure that people don't die alone in the hospital?
Dr. Hayes, do you know of any policies? Because I would say that unfortunately we don't, and that has been a really difficult thing. A lot of nurses and providers I know, especially at the very beginning of this, spent time when their patients were dying and made sure that someone was at the bedside. We don't have any policies that would stop someone from dying alone in the hospital.
Okay, I've heard of things like that at some institutions. As far as I know here, we do the best we can with the people we have, but it's hard because a lot of the staff are also very busy, and we don't have a lot of people coming in electively or a lot of volunteers available.
Right.
Anyone else have any thoughts or comments?
Edwin, I was just going to say, this is a divya uja. The hospital has tried as much as possible given the terrible circumstances, and they're trying to at least make sure some of the patients who are very sick are able to at least FaceTime. As you know, they have designated iPads and certain other mobile devices. It's not the same as the touch of a living person, but it is something. So they have mobile devices and iPads that are designated for this kind of a situation.
Yeah, that's a great point, Dr. Ahuja. And each intensive care unit does have an iPad, and they've tried to make sure to let each patient use that for a certain amount of time during the day. That has been very beneficial, especially for the COVID positive patients who have elderly family members who want to see them towards the end of life. They feel much safer getting on a Zoom call or Skype than they would coming into the hospital and exposing themselves to an increased risk.
Great. Any other questions for Dr. Thompson? Well, great. Thank you very much, Dr. Thompson. I really appreciate it. Really appreciate what your team is doing. It's very important. I feel like everyone is in some degree of kind of, I don't know, it can be very traumatic dealing with something like this. So it's very much appreciated.
And you guys are on the forefront of it. So we appreciate what y'all have done as well.
Again, thank you, sir. And with that, I think we'll transition to our last speaker of the evening, possibly the most important, Dr. Brenner, to talk a little bit about prevalence and how to interpret these kinds of tests that we're all feeling out and trying to figure out how useful they really are. So Dr. Brenner, I'll turn it over to you to kind of get us back to the fundamentals of what all of this stuff even means.
Thank you, Edwin. Can you hear me?
Yes, I can hear you.
And can you see my screen?
Yes, sir.
Wonderful. Okay, whoops. I want to congratulate the speakers so far. Caroline, Derek, wonderful as always, and Divya, full of knowledge, and Dr. Thompson, full of balance and wisdom about difficult end-of-life decisions. So I'm a little bit embarrassed to be coming at the end of these to talk a little bit about things which are not commonly discussed in the context of citywide infectious disease. So I'm talking a bit about sensitivity, specificity, prevalence, and predictive values, and even some more in this era of COVID-19. And many of you will know all the basics. There may be some people for whom this is a new way of looking at things. There may be something at the end which is new to many people. So at peak of what we'll be discussing 2x2 tables, sensitivity and specificity of diagnostic tests, notion of adding prevalence to the 2x2 table, and then discuss a little bit about some Excel tools that can help us work through predictive values of positive and negative tests. And at the end, even adding a little bit of high school algebra to make some distinction between what you might call true prevalence and apparent prevalence. Because if we're doing a survey, for example, to see how many hospital employees or nursing home residents have antibodies against the virus, we will get a certain answer from looking at our test data, but that's just the apparent evidence. And how can we get some estimate of true prevalence? So we'll be looking at a number of these different things here. Why are we doing this now? Well, we've been living through this era of having an initial focus on RT-PCR to diagnose cases. It gives us information about the incidence of new infections, but not progressive use of antibody tests to see who's already been infected. And we hope that presence of antibodies will be long-lasting and indicate long-term immunity, although we don't know all the answers to those points yet. So let's see if I can move this away here. Right, okay. So it's useful to have these epi basics in mind, because sometimes we're looking at test results for an individual patient, but sometimes if you're dealing with a prison population or a nursing home or students coming back to USC, you're dealing with information about dozens or hundreds of tests, so it's important to have some epidemiologic perspectives there. I like this slide here. Depending on your specialty, you may have a certain favorite tools. So surgeons like their scalpel, cardiologists like their EKGs, psychoanalysts like their couch. So what's the favorite tool for an epidemiologist? You might call it a 2x2 table. It doesn't seem as exciting, but it's a way to help us think through a lot of different issues. So here's a 2x2 table getting ready to work. You can see why it's called 2x2. And with some helpful labels, both to the left, here we're talking about test results, positive and negative. We're talking about persons with disease, yes and no, and 4 different possibilities. So this is very basic, of course. So the question of sensitivity of tests we'll discuss on the left side of the 2x2 table. In red, sensitivity will be discussed there, and prevalence will be discussed on the right side on the blue side, and just some other nuances to follow a bit later on. So looking first just at the left side, so persons who do have the disease, and looking at test results. Although actually, if we're talking about RT-PCR, looking at the question of people with disease, if you're looking at antibodies, you're then looking at people who have had the disease. So sometimes the verb is in the present tense, sometimes in the past tense. So obviously, if you test 100 people and you have a positive test for 80, then what we call the sensitivity of the test was 80 out of 100. This is even better. Look at this, 100 people with a disease, and you do a test, find, oh my goodness, 90 out of 100. Wow, that's pretty good sensitivity. And how about this? Out of 100, you find 98 positive, sensitivity of 98%, my goodness. Well, sensitivity 80, 90, 98. Why not have a test with a sensitivity of 100%? Why not go all the way? And so we often ask ourselves this question, why aren't our tests perfect? This could be discussed at some length, but generally perfection is seen only in Never Never Land, but not in the real world. Looking at the right side of the table, so here we have people who don't have the disease, and we're doing perhaps nasopharyngeal swab, and we hope everyone will have a negative test. Well, in this case, we have 85 out of 100 without the disease have a negative test. Now we're talking about specificity, 85%, not too good, we'd like to do better. Here, 95%. And here, my goodness, this is great. 99 out of 100 people who don't have disease have a negative test, just one is a positive test. This should say 99% specificity, okay? Why not have 100%? Well, again, in the real world, we don't get to 100%. So putting the whole 2x2 table together, people with and without the disease, and without positive test results. And in epidemiology, we like to give each of those cells a name, A, B, C, and D. But remember where you start in the upper left with A, and then B, C, and D. And then we have terminology, true positives. Why are they true positives? They have the disease and they have positive test, or they've had the disease and have a positive antibody test. Okay, and down here, true negatives, don't have the disease, have a negative test. So far, so good. But this isn't good. People who have negative tests, although they do have the disease, and this is very upsetting also, people have positive tests, but they have false positives because they don't have the disease. And you see that in 2 of the 4 situations, we can put a smiley face because we're happy with the results. But in 2 of the 4 situations, we can be unhappy because the results are negative. This is helpful, so it gives us 3 different ways of describing what's happening in cells, either by the letters A, B, C, and D, or the labels true and false, positives and negatives, or just by smiley faces, okay? Now, it's possible to make an Excel spreadsheet, which I'll try and show in a second. Here's a spreadsheet where you can put in some numbers in blue, put in the size of the population tested, what's the expected prevalence of disease in the population, what's the sensitivity of the test you're using, and the specificity. So if you put in those 4 numbers into the spreadsheet, which by the way, I can send to Edwin and she can make this available to everyone. The spreadsheet then fills out, let's see, population tested 1,000, prevalence is 1, which means 100%. So, and the sensitivity is 100%. So everybody with the disease has a positive test, and that's it. Very simple. Okay, everything is perfect. An extreme example just for this demo, but in the real world, things wouldn't quite be that way. This is a screenshot, by the way, of the Excel spreadsheet, how it might look. And here we have a population tested to get 1,000, but a prevalence of just 0.05, 5%. And then you can see that the spreadsheet then is said, all right, that means the condition is present in 5%, which is 50. By subtraction, 950 don't have the condition. Sensitivity is 95%, so 95% of 50 is 48, and the rest you just fill in the same way. So what I'd like to do is look through some examples going beyond, looking at how Excel would calculate these things. As shown here, the predictive value of a positive test is only 48. Why is that? Because overall we have 143 people with positive tests, but only 48 of those are true positives. We have more false positives than true positives. So the predictive value of a positive test is very discouraging. It's only 30%. And when the patient says, what does my positive test mean? I say, well, according to my calculations, there's a 1 chance in 3 that you have antibodies, or that you've recovered, or that you have the virus. Well, here are some more realistic examples from the calculator. Look on the left here. Well, look at both sides. In both cases, we're testing 1,000 people. On the left, we have a situation with high prevalence. 50% have had the condition. On the right, only 5% have had it. But we have the same sensitivity and the same specificity for the diagnostic test. On the left side, where the condition is quite common, the predictive value of a positive test is 90%. Because look at the top row there, of 525 people with positive tests, 475 have true positives, so that's quite good. But on the right there, you see the opposite. The prevalence is low, and Divya, you mentioned this also, that the predictive value of a positive test is low when the prevalence is low, so the predictive value of a positive is quite low there, okay? So we see, to summarize here, the same population size tested, 1,000 people, same test with the same sensitivity and specificity used, prevalence very different, and therefore the consequence is that the predictive value of a positive test is much lower in example 2, okay? Now, it's not that sensitivity and specificity depend on prevalence. That was something that was mentioned a month ago. Sensitivity and specificity are characteristics of the test itself, whereas prevalence refers to a characteristic of the population being tested, that is, to what proportion or what percent of the population has the condition in question. But the predictive value of positive and negative tests do depend on test characteristics and on population characteristics as well. We could discuss at some length the question of how do we know what the sensitivity and specificity of the test are. The manufacturers give us information about that, but in the real world, the test's sensitivity and specificity may not be as good as what the manufacturers told you, because so much depends on numerous things. For example, the ideal sensitivity may depend on how well the swab is taken. Is it a true nasopharyngeal swab? Supposing it's just a nasal swab? Supposing it's just an oral swab? Supposing the specimen has not been kept at the right temperature on the way to the lab. If you see what I mean, there can be numerous reasons for having a degradation of the manufacturer's claimed sensitivity and specificity. Final point here now is the distinction between what you might call apparent prevalence as opposed to true prevalence. I'm abbreviating those PA and PT. For example, there's talk going on now about possibly screening all the students coming back to USC in the fall. So is someone really thinking of doing 25,000 or 30,000 tests? And when we do those, we'll come up with a certain number of people with positive tests. And the question is that true prevalence or apparent prevalence, and how can you go from one to the other? So here, imagine that we've tested 1,000 people, such as healthcare workers or students, for presence of antibodies, to get an idea of how many have been infected, had recovered, and hence may be immune. Okay, so we know the test results from 1,000 tests. And look at the 2x2 table, 1,043 positive. So the apparent prevalence is 143 over 1,000 is 14%. But that's only the apparent prevalence. The true prevalence, as you can see from the 2x2 table, is only 50 over 100, is 0.05. But we don't know the true prevalence. If we did, we wouldn't be doing the testing. This 0.05 shows up because we've entered that into our spreadsheet. All we know is the 143 over 1,000, and what the test manufacturer tells us is what the sensitivity and specificity of the test are. So how could we reconstruct the 50 based upon the number 153? Okay, so go back to our 2x2 table again. Okay, and let's, instead of putting in numbers, well, look at the bottom of the screen. We have PT means true prevalence, which is unknown to us. But true prevalence times the sensitivity of the test will give us the numbers that are up there. Sensitivity times the true prevalence would be the numbers in cell A. And down here, 1 minus the sensitivity. So 1 minus 95% could be 0.05 times the true prevalence. That'll be the numbers down there. Likewise, here would be specificity times 1 minus the true prevalence, and up here the other number. So if you look at all those together, what you could say, oh my goodness, this is so interesting. The apparent prevalence is equal to the sum of the cells in A and B. But we've seen algebraically what the numbers in A and B mean. So all we really need to do, given PA, is solve this equation for PT. And this takes us back to high school algebra. And when we do that, we come up with something a little unusual. The true prevalence is equal to what? The sum, and you can do this this evening before you go to bed, the apparent prevalence plus the specificity minus 1 divided by the sum of sensitivity and specificity minus 1. So interesting. By the way, let's look at this for a second. Supposing we had perfect sensitivity and perfect specificity, then the true prevalence would be what? It would be apparent prevalence plus 1 minus 1, which is 0. So it's just the apparent prevalence in the numerator. Denominator would be 1 plus 1 is 2 minus 1, which is 1. So we have 1 in the denominator. Oh my goodness. So when sensitivity and specificity are perfect, then true prevalence is equivalent to apparent prevalence. But in the real world, that's not how things work out. So let's look at this here. Here's the formula. Let's look at the top here. There's the formula for deriving true prevalence. If you've worked out the apparent prevalence by doing some testing. So given here, apparent prevalence of 1.43, sensitivity of, do I have this right? Specificity of 0.9, sensitivity of 0.95. This works out to true prevalence is 0.0043 over 85. There it is. And that gives us then exactly the true prevalence as shown. Even though we didn't know it, we were able to infer it by going back to this formula. Now, the formula has certain strengths and certain weaknesses, and which we can't go into right now. There are conditions when it won't help you. Many times it will. If you go to PubMed or to Google and look for publications which discuss apparent versus true prevalence, you'll find a number of articles. The interesting thing, as noticed on the right, is that most of these do not come from the human medical literature. This one happens to, but it mostly comes from the veterinary literature. So I'd have to congratulate our friends who work in veterinary public health, studying not epidemics, but epizootics. And they're very clear about the distinction, and there are even several online calculators run by schools of veterinary medicine which make this distinction. So it's a nice reminder about the One Health world and why we need to pay more attention to our veterinary epi colleagues. And keeping some of these tricks in mind can help us sometimes when we look through tests, not for individuals, but look for tests done in large numbers of people, such as nursing homes, healthcare workers, or students. So there again, we have surgeons like the scalpel, and we like the 2x2 table. So I hope this has not been a bit too out of line for Citywide, but I hope this has been useful as a way to think a little bit about an epi way of thinking about the data we'll be collecting. Thank you so much.
Great, thank you, sir. Anyone have any questions for Dr. Brenner? Dr. Brenner, how close do you think we are to understanding the prevalence of COVID-19 in South Carolina, in the US?
You mentioned, let me just see if I can get my screen back here. Oops. Yeah, I think if you look at the DHEC website, we have now, Michael Kaska, is it about 10,000 cases now going on 11,000? It is written there in a couple places that the estimated number of cases may be much greater than that, possibly up to 8 times as great. I think those estimates of how much greater unknown cases are than known cases may be based on some data that were collected a number of weeks ago. Things have changed now because increasing testing by so much. So initially we had just the DHEC lab doing testing, and then Prisma Health, MUSC doing a lot of data, doing a lot of testing, and Quest and LabCorp, and now testing being done in various neighborhoods in different places. So the proportion of tests which are positive is coming down as we increase the number of tests. I don't think we have a good sense yet of the proportion of the population which is infected, because think about it this way: there's a broad spectrum of illness out there, and people who are very sick and wind up in intensive care are being tested, of course. Those who are sick enough to go to the hospital wind up being tested. But those with mild, you might almost say influenza-like illness symptoms, except for loss of smell and whatnot, we have many such people out there, and I don't think we have a good sense of how many of those are below the tip of the iceberg. My sense is they're probably large numbers, and Jerry Gibson, you've been following the literature quite closely. What is your best estimate, Jerry, of the number of true infections out there compared to the number of reported infections in the USA? I'm not talking about Korea or China right now.
Eric, who knows? In fact, what I should have done is taken apparent prevalences, which have been done for the states of New York and Washington at least, and run them through this very nice adjustment. Of course, it depends upon knowing the sensitivity and specificity of the tests that are used, and they're going to be variable. So I don't know. Remember in New York City, it looked like the prevalence might have been as high as 20%. That's the apparent prevalence. In Connecticut, it was 2%. In Seattle, it was like 2 or 2 to 4. South Carolina, we don't know. The crudest way to look at it would be to say, what are the number of positive tests and what's the population of the state? That's going to be very small indeed. So I think that we all can benefit from learning more and using this formula that you've given us. I have just one suggestion. It may be a little bit easier to use in looking at the formula for getting the apparent prevalence from, the true prevalence from the apparent prevalence. Got the right stuff there. You can either reconstruct the 2x2 table, or you can just use A, B, and C, and D for the different cells in the corner. I'll try and figure that out and send it around. Certainly talk to DHEC about it, but thank you, it's very helpful. So the veterinarians can teach us a lot.
Indeed. We're learning a lot more every week, and we heard that so many ways today. And Edwin, this was really wonderful to have Caroline talking about plasma donations, and Divya about clinical care, and Dr. Thompson about palliative care. A little bit of epi. It shows that we're kind of all in this together, and learning a lot. I bet a month from now we'll even know a lot more. But
maybe one more useful thing to think about is that DHEC is actually doing a prevalent survey, a fairly good one, of all the nursing homes in the state. For obvious reasons, it's terribly important to be able to cohort the infected people from the non-infected people in these very, very high-risk settings. My guess is the prevalence will be high enough in nursing homes that the true prevalence will not be that different from the apparent prevalence. But we need to sit down and calculate that out, and we will.
Yeah, that's fantastic. I think that all of this really shows that with, time and thoughtfulness, we really can do something effective about this. And I really appreciate all of you coming to talk and listen. Thank you to all of our speakers for taking the time to be here. We'll work to try and get the slides. And I believe this is being recorded as well, so we can distribute that to folks who want to share it with other individuals to learn or open up dialogue about these things. Does anyone have any closing thoughts before we close it out?
One last thought, just as from clinical epidemiology. This is why, we're told as bud and, in second year of medical school or first year, don't test everybody with a test who you have strong clinical suspicion for. That's how you get the prevalence you're applying the test to down. You get the prevalence up, and therefore your test becomes better and your predictive value gets better. We all learn that in nursing and medical school. Apply your test to people who clinically look like they've got the condition, and you'll get a better result from your test.
Yeah, I agree. And I think that we're doing some real-time testing of that testing to see what happens when people do that and apply those kinds of principles appropriately or not so appropriately. Absolutely. Well, thank you all again very much. I think we'll leave it there. If you need anything or trying to get the slides or the recordings, we're going to try and send that out. But if for whatever reason you don't get it, reach out to me. I really appreciate your time. I think we're going to take a little hiatus for the summer. So we'll be gone for a couple of months, but we'll come back later. We will be back. And we'll reach out to you once we get that set up, but we'll probably be gone for a couple of months to kind of regroup. So thank you all so much for being here for this last little conference of this particular academic year, and have a great night. Thank you.